Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor Nick Bostock to talk about the latest news affecting general practice. Coming up, we're talking about list cleaning after an analysis by Nick showed that 350,000 patients have been removed from GP practice lists, resulting in a loss of around £45 million from practice funding. We'll be talking about why this happens and the impact this has on individual practices. We're discussing GP contracts after the first area in England agreed a local variation to PCN contracts to help deliver neighbourhoods. BMA fears about what neighbourhood and integrated health organisation contracts could mean for general practice, and also whether financial pressures on the current GP contract could make GPs back an alternative model. And we'll be looking at the impact successive governments' obsession with GP access has had after a report from the House of Commons Public Accounts Committee found that practices struggle to provide the care frail older patients need because they're overwhelmed with targets linked to improving access. Our good news story this week is about an initiative in Greater Manchester that has helped cut hazardous prescribing. So Nick, lots to talk about today, but let's start with list cleaning and your analysis of what's going on with that. Firstly, for people who don't know, what exactly is list cleaning and why does it happen?
The list we're talking about here are GP practice lists. It's the lists of patients registered with each GP practice across the country. And list cleaning or list validation or list reconciliation is basically a process meant to check that the lists are accurate. In England, there's a regular process in which practices are asked to share their registered list with an organisation called Primary Care Support England, PCSE, which then checks it against a central database. Essentially, what they're looking for is what are often referred to as ghost patients, people who are still on a practice list, but actually they've moved away without informing their GP, or perhaps they've even died and the practice may not realise immediately. But what often happens, particularly when list cleaning is intensified, is that legitimate patients are caught up in this and removed from practice lists alongside any ghosts. And that means potential problems and stress for the patient, as well as extra work and lost income for GP practices.
Yeah, and you've been looking at this recently in detail because there's been a really big list cleaning drive. What's going on with that? What did you actually find has happened?
We always keep a pretty close eye on stats around the GP workforce and numbers of patients per GP and so on. I noticed recently there'd been a really big drop in the number of patients registered with GP practices in England over the past 6 months or so. I wondered what was behind that. And in October last year, there were 63.94 million patients registered with GP practices in England, roughly. But by April this year, that had dropped to about 63.6 million. So the total number of registered patients came down by about 350,000 in that 6-month-ish period. That's a huge drop. It's by far the largest in at least the past decade or so. And it's been driven by what the NHS says is ongoing work to address list inflation. But a reduction in patient numbers on this kind of scale has some really significant implications for general practice. For one thing, it means a big hit on funding. GP contract for 2026-27, the current financial year, was meant to bring a funding uplift of just over £600 million. That's once the final sort of pay rise for GPs was factored in. But practices are paid per patient. They receive, on average, £130.07 per patient, and stripping 350,000 patients off of practice list means total funding drops by around £45 million. That's about £7,000 per practice across England, although these things obviously are never evenly spread. And we've heard from some practices with below average list sizes that they've lost as much as £25,000. That's a big hit for a practice of that sort of size. It's a fairly big hit for any practice. The way this works is that when PCSE identifies a patient they don't think should be on a practice list anymore, often because they haven't responded to a request to confirm their details, or when mail sent to them is returned undelivered, they put what's called an FP69 flag on the patient's record. And GP practices then have a period of time to contact the patient and, confirm their address, establish that they should still be registered with them. If the practice can't get hold of the patient in time, then they're removed from the list. And obviously that may be legitimate, but if they just haven't got hold of someone who is a legitimate patient, then, that person would be removed anyway. We don't know the exact scale of inappropriate removals, but GPs I spoke to said the list cleaning process has been aggressive. One said 500 patients had been removed in total from their practice and that dozens had been reinstated after staff spent hours calling around. So, a really substantial proportion of removals in that case were in fact legitimate patients. Another said they'd reinstated something like 30 to 40% of patients flagged for removal. But they said it was inevitable that patients would be cut from their list inappropriately just because they hadn't managed to contact them in time. And what that means is that when patients who may not visit their GP very often do actually need care, they turn up and find they're no longer registered, and potentially then they end up heading to A&E. The BMA pointed out that a single visit to A&E costs far more than the amount GPs are paid to look after a patient for a whole year. So inappropriate removals are absolutely a false economy and can end up costing the NHS a lot more than it saves by taking someone off of a practice list. GPs pointed out too that general practice overall is underfunded. If this whole process strips out more funding from the profession, particularly at a time when the government wants to move more work out of hospitals and into primary care, that's really damaging. So they're also calling for this money to be recycled back into the profession. I mean, either through an increase in the payment that practices receive per patient or through some kind of other mechanism.
Are there any specific groups of patients that are particularly affected by this?
GPs I spoke to said patients whose first language was not English, older patients, those who are vulnerable for other reasons, patients who are young, mobile, may not use their GP practice all that often. All of those people are particularly at risk of inappropriate removal. And that's obviously because in the case of somebody whose first language is not English, if a letter comes and they don't manage to read it, or there's something that's lost in the communication process, they may be removed simply because they don't reply, because they don't understand what the letter is for. One GP said patients may simply have changed their phone number and not informed the practice, or moved locally and therefore not responded to a letter. And the fear is very much that more vulnerable people are far more likely to be caught up in this. Families moved between local authority housing, for example, or those with mental health or learning difficulties as well. It's just anyone who for any reason may be less likely to respond to requests to confirm their details.
And how has this affected individual practices? You've kind of talked a little bit already about some of the financial impacts and the workload impact it's had. What does it really mean for practices, though?
The average practice list in England now is just over 10,000 patients. And, as I kind of touched on, I spoke to one GP whose practice had around 8,500 patients and had seen that cut to just over 8,250. So it's a loss of £25,000, £30,000 maybe from its core funding. Another practice, a university practice, had lost about 500 patients. Weighting of core funding through the Carr-Hill funding formula for general practice means that those patients, assuming lots of them are younger, are likely to generate lower than average payments per patient, but losing that many patients could still lose you around £50,000 off of total core funding. So these are significant financial impacts, but that's not the only factor. Practices, want to make sure that removals are accurate. So they spend time calling around patients who are flagged for removal, trying to verify who should still be on their list. But that can take hours and hours of extra time for practice staff, and obviously practices aren't awash with spare time. One GP said partners sometimes end up pitching in and having to take part in this process of calling around to check whether removals are appropriate or not. So those are partners, GPs, who could be spending that time perhaps seeing patients or doing something else to do with the running of the practice. So there's a really big workload impact. Practices are also worried about patients who've been inappropriately removed, not through any fault of the practice, turning up and being angry about it, and there's a risk of complaints therefore. So the impact is significant, it's multifaceted, especially when the removals are on this kind of scale.
Yeah, definitely. There was also an issue, wasn't there, with the time that practices have to respond to patient removals that came up when you were speaking to people, wasn't there? That seems to be causing practices some particular problems.
Yeah, so practices used to have 6 months to try to contact a patient after they were flagged for removal. But from October, which is when this big drop in registered patients begins, the rules seem to have changed. So PCSE's website says practices now have 3 months after an FP69 flag is put on a record to confirm a patient's details before they're removed. So the time period for checking on a patient identified for removal from a practice has halved, and that time constraint seems to have been a real issue for practices, and it's particularly in the context of this aggressive list cleaning drive. Basically, practices have had so many patients flagged for removal in many cases that they can't keep up. They're saying they've been overwhelmed, and working through them to check whether removals are appropriate takes a lot of administrative time, as we talked about, and practices simply just don't have the capacity for it. That all means, in the end, that the chances of an inappropriate removal go up.
So up next, let's talk about GP contracts. Again, loads to talk about this. So first, let's talk about PCN contract variations. We talked about this on the podcast a while ago, didn't we? This is NHS England introducing the ability for integrated care boards, ICBs, to make local variations to the network contract directed enhanced service. So that's the contract which governs how primary care networks operate. This is to allow ICBs to start work now on developing neighbourhood health. Any variations that are introduced need to be agreed with GPs locally and approved by NHS England. And last week, we saw the first of these variations that we know of being introduced in Kent and Medway. What do we know about this, Nick?
As you said, this is the first local variation to the network contract DES. Directed Enhanced Services, DESs, are a contractual mechanism for paying practices for work outside of their core responsibility. So the core stuff is funded through the Cahill formula. And unlike local enhanced services, DESs are normally agreed on a national level. When a DES is agreed as part of the National Contract for General Practice, it's offered on the same terms to practices across the country. But from May, NHS England said that ICBs could apply to vary the network contract DES locally. That's the DES that pays for practices to participate in primary care networks, in PCNs. The reason for allowing this variation was to create more flexibility to develop neighbourhoods. ICBs are under pressure to get that agenda moving, but obviously the contracts that were promised as part of the 10-year health plan, single neighbourhood and multi-neighbourhood contracts, which were supposed to sort of underpin the development of neighbourhood models, those haven't yet materialised, and there's a consultation that's meant to be coming, and those contracts are still meant to be on the way, but like I say, they haven't yet materialised. So that's the context. And in this case, the ICB has agreed a deal with local GPs around varying the DES. Kent and Medway is among the most under-doctored areas in England, so a really high number of patients per GP on average. And this deal is promising about £10 million of new investment every year in general practice. Practices are going to be expected to deliver extra support in return for that money, including advanced care planning discussions, comprehensive geriatric assessments and structured medication reviews. And this is all aimed at a group of about 92,000 patients in that area. That includes care home residents, people on palliative care registers, housebound patients with severe frailty. The ICB, so this is where the motivation for this focus of this development, this deal, lies. ICB says this particular group of patients makes up about 5% of the Kent and Medway population, but it accounts for 30% of hospital admissions. And, this particular cohort, frail patients, often ends up in hospital for above average amount of time once they're admitted. The focus of the deal is very much on keeping avoidable hospital admissions down and also on improving outcomes for this particular group.
Yeah, it's interesting, isn't it? Because the neighbourhood health framework put out by the government and the stuff that NHS England have put out about neighbourhoods, it's very much, these are the kind of patients that they see integrated neighbourhood teams when everything gets going, sort of focusing on these people with frailty, people on palliative care registers, older people with multi-morbidity. This deal in Kent and Medway, you've touched on it there, it's delivering more money for general practice, so it seems quite a positive development. Do you think this is a good move?
There have been some concerns about local variation, meaning there's a risk of postcode lotteries emerging, different services in different areas, more variation in levels of funding going into general practice. So that's the risk with varying parts of the national contract at a local level. I mean, on the flip side, obviously, you could argue that the services different areas need vary. So therefore, local variation is an essential part of meeting the needs of different populations. So that's also a factor. But, we've reported before on how local and directed enhanced services funding could be hoovered up by neighbourhood models. So there's also a potential for a really key income stream for general practice to be pulled away from individual practices and, move into these at-scale plans instead. But this does appear to have unlocked some additional funding for general practice, and that's much needed. You could also say that the deal has been signed off by the area's LMC. So it has approval from GP leaders locally. And they've said that this arrangement basically makes sure that GPs are at the heart of the neighbourhood plan for this area. It's also, obviously, as we talked about, it's enabling the area to get moving on developing their neighbourhood model without having to wait for all these other contracts to come through. So for now, it does seem like a fairly positive development. And clearly we'll have to see how that pans out, whether ultimately the extra work GPs are expected to do is fully covered by the extra money coming in.
It's interesting what you're saying there, because the ICB, when it put out the statement about this, it did sort of say that this is a way to get neighbourhoods moving, GP-led approach to neighbourhoods moving without having to, under existing contractual arrangements, much like you've been talking about. But because, we don't have these contracts, which we've been waiting for, I mean, it's almost a year, isn't it, since the 10-year plan came out. And so we've been waiting to see what these new contracts would look like for a year, and we've still no sight of them. But because we don't have those contracts, do you think we're going to see more ICBs using these PCM variations to get started with neighbourhood working?
So our understanding is that ICBs have been pushing for a while for flexibility of this type, so that they could get on with neighbourhoods without having to wait for these new contracts to appear. And I think there's definitely an argument that they could have done something similar without flexibility from the network contractors, simply by investing more in general practice through local enhanced services. That's already something that, is a local flexibility that has been available to ICBs for many years. And I'm not quite clear why they haven't seen that as an option, but potentially it's because ICBs are more keen to put money in through an at-scale arrangement of some sort, so the network DES better fits around that. Yes, there will undoubtedly be more variations like this one to come, and GPs will be watching to see what the scope of those deals is, how much extra funding they bring, what extra work practices are asked to take on. I think the hope would be that ultimately, if an initiative like the Kent and Medway one can reduce hospital admissions and therefore cut costs for hospitals, potentially that could free up more funding within a system. Maybe that gives more room to double down on the left shift and bring even more investment in primary care. Obviously, that's much further down the track. But I think you'd hope that these sorts of DES variations are sort of a stepping stone and a sort of platform, the beginning of a much more comprehensive shift towards neighbourhoods.
I was talking to someone earlier about these local PCM variations, and they were saying that they've heard on the grapevine that there are more of these being discussed at the moment. And I think, what that person was saying to me is it might be places where PCNs are already coming together to deliver local enhanced services, where there's already a system in ICBs where they commission local enhanced services across a PCM patch. Those ICBs might be particularly keen to kind of roll all of that into the network contract DES rather than having it all in separate pots. So those could be areas potentially where we might see these roll out a bit more quickly than other ones, maybe.
So it was already an intention a few years ago, wasn't it, that local enhanced services would start to be commissioned at PCN level rather than in through sort of agreements with individual practices. This very much fits with that sort of direction of travel, doesn't it?
Yeah, definitely. I mean, talking about neighbourhoods, there was another story that you wrote this week about new BMA guidance on neighbourhoods and integrated health organisations. I mean, the BMA thinks that integrated health organisations, or IHOs in particular, could have a really negative impact on general practice. What did it have to say about that?
Yeah, so the 10-year health plan, that came out last July, said that some NHS organisations could become IHOs. The idea here is that they would take on responsibility for the entire health budget across a region. So control of NHS funding for everything across primary and secondary care. The first organisations in line to be granted that status are a kind of select group of hospital trusts. 6 trusts have been designated advanced foundation trusts. So these are high-performing organisations that are meeting expectations around finances and quality of care. And 2 of them in Northamptonshire and Northumbria are currently going through an extra assessment process that could win them a sort of approval to become IHOs, so the step on. And that's potentially from as soon as the coming financial year. So the 10-year plan said organisations other than hospitals and potentially GP-led organisations could ultimately become IHOs. But for now, hospitals are the only type of organisation in the running to take on that status. So the BMA's concern is that brings a scenario where hospital trusts are running general practice in some parts of the country a step closer. And they've warned that ultimately they see that as a likely outcome of the current policy direction. Hospitals running general practice would mean the current partnership model, independent contractor status for GPs would be at risk potentially, as the BMA says. And that could threaten all the benefits that come with it around continuity of care and relationship-based care and so on.
The BMA really doesn't like IHOs. So I think as these things develop, we can expect to see more and more objections coming out from the association about that. And I think actually I get the impression they don't like it. I mean, obviously they don't like it for GPs, but I'm not quite sure how they really see it as a good option for hospitals either. So yeah, I mean, obviously we have to see how those 2 areas develop. And obviously the other big thing about contracts that we've not really talked about on the podcast in detail is that decision by the BMA GP committee to ballot the profession on a plan B. That was a breaking news story just as we came in to record the last news podcast, so we only mentioned it very briefly. So the BMA GP committee in England voted overwhelmingly actually to ballot GPs an alternative approach to GP contracts that would allow GPs greater freedom to provide private services to their patients. This followed a vote at the UK LMC's conference that called for a means-tested subscription-based service or a hybrid model. Since then, the GP committee has said it will be engaging in an extensive consultation with the wider profession over whether there's a support for this move over the summer. So will GPs want to do something like this? Nick, last time we spoke, I talked through that debate at the UK LMC's conference and what some of the delegates were saying in that. That motion passed really overwhelmingly. But I think I mentioned there was quite a lot of talk about the GP committee across the UK having the ballot kind of in the back pocket, as it were, when it comes to negotiations. The GP committee have told us that they have apparently up until next June 2027, to conduct the ballot. So it's not really clear when it would take place. But do you think, GPs would be up for it when it comes down to it? Do you think there's wider support outside of LMC representatives for a move towards a new model of general practice?
My guess would be that most GPs would not go private, at least not willingly. But the fact is, there is real anger and real worry about the level of funding currently coming into general practice. Funding hasn't kept pace with rising costs over recent years, maybe not just recent years, for some time. Practices have really struggled to stay afloat. Numbers of GP partners have dropped rapidly. Attracting new ones in isn't easy. We've reported about the jobs crisis in general practice, qualified GPs struggling to find work, despite the fact that practices across the country are swamped with work. And that's happened because practices often just can't afford to recruit. We know from polling that lots of GPs are thinking about leaving general practice. Sometimes it's to quit, sometimes it's to move into another profession, sometimes it's to go and work abroad. And it's often because they feel it's not possible to offer the kind of continuity, relationship-based care that they came into general practice to try and be a part of. So in that context, it's not surprising perhaps that people want to explore alternatives. Many would be keen to be able to top up their income by offering some private services alongside the NHS general practice work that they do. That could be a way to make their practice more sustainable, bring in more staff and so on. Others will not want to go that way at all and will feel that the government just needs to fund practice properly, not to try and make general practice prop itself up with private income in that way. But the point is, you can see why it's come to this. GPs keep saying general practice is underfunded and unsustainable. The government keeps not doing anything about it or not enough about it. So people are starting to look at alternatives because of that context, and that context that's been going on for, a decade or more. For that reason that people are looking at things like dentistry type models or the kind of model that currently operates in Ireland.
I think whether or not GPs will vote in favour of something like this really depends. You've kind of touched on it a bit. Really depends on what the actual question on the ballot is, doesn't it? What is the BMA going to ask? Presumably this is what this consultation over the summer will kind of work out, what kind of appetite there is for what kind of move. For example, like as you said, quite a lot of GPs might back practices having the ability to provide private services to patients on their list if they're not available locally on the NHS. I think I mentioned last time that was one part of the motion at the LMC's conference in Belfast. I mean, most practices have patients on their list paying privately for weight loss jabs or for minor surgery to remove skin lesions, things like that, even ear syringing. If patients are already paying for those things, why shouldn't they be able to pay their GP practice? I think there's a lot of GPs that probably support that. Obviously, the government of the day might not like it because they'd be concerned that practices might be spending too much of their time on private work. But lots of GPs do argue that being able to do things like that, like you said, actually, Nick, would make their practice more financially sustainable, ensure they were better able to provide NHS care. But then when you get towards talking about a means-tested model or even a full-out private service that would run alongside NHS practice, I think that's where people might be a bit more concerned. And even if they did support something like that, what exactly would it look like? How exactly would it work? There's so many questions on that front that I expect any ballot within the next year would be more about, the principle of it. And then the GP committee would have to come back with some more detailed proposals about how it might actually look. And then obviously it would have to kind of be agreed, I suppose, to some extent with the government if there was going to be a certain level of NHS provision as part of that model and how that might work. I mean, you mentioned the dentist as well. There's been a lot of talk about a dentist-style model with all of this, and that was actually mentioned in that LMC motion. But I think that would send loads of alarm bells ringing. I'm not sure there's many people who would want to see the current dentistry model being used for general practice. I mean, in some parts of the country, it's almost impossible to get an NHS dentist, and that's often in some of the most disadvantaged parts of England, and I don't think anyone would want to see that happen in general practice. So I think the BMA would do well to steer away from that dentistry comparison if they don't want to alienate patients with all of this.
To give a sort of personal example on that, it's just a bit of evidence around the potential for a slippery slope. My wife's family, the dentist that they were with since she was a kid, we all joined as a family. That was our NHS dentist for a couple of decades. And 5 years ago now or something, they wrote to us and said, if you want to stay with them, it's now a subscription model. So we would have had to pay, I can't remember how much, but it was a fairly substantial sum if we wanted our family to remain with that dentist. And they decided at that point that they were exiting the NHS because they felt that they could get a better income out of going wholly private, and they just feel like the NHS bit was no longer worth it. That's the risk, I think. NHS services start going down that mixed model route. Where does it end? And do they at some point go, do you know what, this private thing's
more lucrative, better,
exactly.
less stressful?
Yeah, exactly.
Yeah, I can't see many GPs backing that kind of option, really. But like I said, you see, there's so many ways this could go, isn't it? An alternative, do they mean providing more private services to their own patients that aren't available on the NHS? Do they mean a means-tested model where, only the richest people would be required to pay, and they would probably do that through some sort of insurance system, and maybe the poorest people would get everything on the NHS and the people in the middle would have to pay for their prescriptions or something? That's kind of how the model in Ireland works. Or are they talking about something in between? And I think what people would back, it depends what model they're actually talking about.
Someone somewhere has got to come up with a model that is sustainable for general practice, right? And if there's this level of feeling that at the moment it's just not sustainable, that's got to change. So, Emma, another story we've done recently is about a report by the House of Commons Public Accounts Committee on supporting people with frailty outside hospitals. That came to some pretty damning conclusions about the impact access targets have had on GP practice's ability to provide care to older, frail patients, didn't it?
Yeah, so Kimberly actually wrote this story, but she's out at an event this week, so I'm going to talk through this one. For people who don't know, the Public Accounts Committee in the House of Commons is the committee that scrutinises value for money when it comes to government projects or service delivery. So, it was a bit of a surprise actually getting this through from the Public Accounts Committee, because it sounded like it should be something coming out of the Health and Social Care Committee. As you say, this report came out of its inquiry into supporting people with frailty outside of hospitals. And the reason the Public Accounts Committee was looking at this is because of how much frailty costs the NHS. Research from 2019 estimates that it costs the UK health system around £5.8 billion a year. And so I guess the committee wanted to find out whether current policies and approaches are adequately dealing with that cost, and the way we're approaching it is the right way to be spending our money. So the inquiry took written submissions, and ministers also quizzed some senior people from NHS England and the Department of Health and Social Care face to face. And what they found was that GP practices are really struggling to meet contractual requirements around identifying, assessing and supporting people living with frailty. So under the GP contract in England, practices are expected to identify people aged over 65 with moderate or severe frailty. And then the patients with severe frailty should have a clinical review, including an annual medication review and a falls risk assessment. The report found that just 17% of this group were assessed in 2024-25, and fewer than 1 in 6 of those had those key follow-ups I mentioned. So the report said that practices' ability to deliver care to their frail patients had been undermined because NHS England had overloaded, and that's the word the committee used, overloaded practices with access targets. It said NHS England had prioritised improving patient access and digital access, and this had left practices unable to deliver on those frailty requirements in the contract. It also said it wasn't really clear who was responsible for overseeing performance on identifying and supporting frail patients, and that planning and policy initiatives around addressing frailty and dementia were confusing and fragmented.
Well, it's interesting. It kind of makes the case for exactly why general practice is in dispute with the government over the contract at the moment, right?
Yeah.
And then it also cuts across the neighbourhood thing that we're seeing in Kent and Medway. It's the same set of priorities that are coming in there. The committee also raised concerns about regional variation, I think.
That was a real concern, actually. The committee found there was significant and unexplained variation between areas, as it put it. It said that NHS England needed to take steps to address this, by setting up a threshold, as it were, for when ICBs needed to intervene in areas of poor performance. And actually asked NHS England to write to the committee and explain what kind of intervention that would be and what would it look like. That was one of its recommendations. The committee also said, and this is quite interesting given the context we're in, everything about neighbourhoods, the committee also said it was deeply concerned that, the cuts to ICBs, which we've seen over the past 12 months, would really hamper any progress in this area. It said that the cuts to ICB staff were insufficiently thought through, and they would undermine ICB's ability to carry out their functions, and that this could undermine well-performing ICBs when it comes to, dealing with patients with frailty, and then limit the ability of poor-performing ICBs to improve. So it was pretty scathing about those ICBs. cuts. There was a fairly damning comment from the committee chair as well, Sir Geoffrey Clifton Brown. He said that the final report showed that in too many parts of the country, GPs were unable to do important work around frailty because they'd been overloaded with new and expanding priorities from NHS England. He basically said NHS England needed to take a long, hard look at what it expects from the health system and GPs, who he said are only human beings running already complicated operations and with limited resources.
Do we know what NHS England has to say about all of this, and what have GPs said?
Well, Kimberly didn't get a response from NHS England when we actually went to them, but the actual report does highlight some of what NHS England was saying during the evidence session. For example, during those evidence sessions, NHS England, admitted that care for patients in care homes needed to improve. It said it was looking at what other healthcare professionals in primary care could do on frailty, for example, whether community pharmacists should be doing medication reviews, that sort of thing. NHS England also told the committee it's setting up a national frailty dashboard, which would take account of all the interventions it expects ICBs to be doing. So that's obviously something that practices and PCNs will need to look out for coming down the track. As we talked about earlier, obviously a focus on frail older patients, those with multimorbidity, is supposed to be a focus for integrated neighbourhood teams. Presumably, these dashboards have been designed to support that. And then apparently there's also a forthcoming modern services framework for frailty, which again I expect is being developed to help support neighbourhood working. In terms of what GPs said, the RCGP said that the report showed that prioritising online access over continuity could have unintended consequences and undermine the care of the most vulnerable patients. The college obviously said that providing care to older patients had become increasingly complex because of the intense workload in general practice, and also pointed out if the NHS wants GPs to improve access and also to deliver on this more proactive care and that prevention agenda, then really practices need more resources, more GPs. Before we go, we've just got time for our regular good news story, which this week is about prescribing in Greater Manchester. This is about a collaboration between the NHS, the University of Manchester, Health Innovation Manchester and the technology company GraphNet, with support from the National Institute for Health and Care Research. And the initiative has helped to deliver a 40% reduction in hazardous prescribing in 43 practices in the area during the past 12 months. Because of this success, the programme has now been introduced across 400 GP practices in the area. It involves a new safety medication dashboard, which uses real-time patient data and evidence-based prescribing safety indicators to identify patients who may be at risk from potentially hazardous prescribing, including patients on high-risk medication who've not received appropriate monitoring or follow-up. Once patients are identified, clinicians can then review patient records and take any action required. The dashboard is regularly updated to refine and optimise existing indicators and develop new indicators that relate to emerging risks. And it's a really good example, I think, of a collaboration between all those bits, the commercial sector, academia and the NHS, and obviously making a big difference in Manchester. Well, that's it for this week. Thanks for listening and thanks to Nick. I'll be back next week when I'm speaking to GP Dr. Emma Ryan, who's the chair of the RCGP's Rural Health Network, about general practice in rural areas and what support practices in those parts of the country need. So do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources on our website at GPonline.com.